Imagine for a second that you install this state-of-the-art security system in your house. Like you wire all the windows, you put motion sensors in every hallway.
A whole 9 yards, right?
Yeah, the whole 9 yards. You attach alarms to every single door. But there is this massive hidden design flaw in the wiring.
Oh, that doesn't sound good.
No, it's terrible. Because when an actual burglar shatters a window to break in, instead of, sounding a blaring siren to wake you up, the alarm system just quietly unplugs itself.
Wow, so it just goes dead.
Right, you're sleeping soundly upstairs, completely undisturbed, and totally unaware that your living room is just being methodically emptied out. I mean, it sounds ridiculous, right?
It does, but it's actually a perfect metaphor.
Exactly. Because for millions of people, particularly those managing diabetes, their body's alarm system, which is pain, just unplugs itself right as a massive structural collapse begins in their feet.
Yeah, and the thing is, the human body really relies on the sensation of pain as this evolutionary defense mechanism. It's that blaring siren that tells you, hey, pull your hand away from the hot stove, or, stop walking on that sprained ankle.
Right. It's there to protect you.
Exactly. So when that neurological wiring is damaged, the physical degradation that follows is just entirely silent, which, makes it infinitely more dangerous.
And that is exactly what we're getting into today. We are looking at how to spot that silent burglar when the alarm isn't ringing. So welcome back to the deep dive, everyone.
Yeah, glad to be here.
This is actually part 3 of our special 4-part diabetic foot care series, and our mission today is all about recognizing the red flags.
It's such a crucial topic.
It really is. And to map this out for you, we are diving into the clinical practice notes of Michael L. Ashley. He's a board-certified pedorthist who's been operating in the Dallas-Fort Worth area, specifically down in Cedar Hill, Texas, for, over 2 decades now.
20 years is a lot of time to spend looking at the failing structural foundations of the human foot.
Yeah, no kidding. And the core theme that just runs through all of his clinical materials is this really hard, distinct line between what he calls retail guesswork and true clinical pedorthic care.
Right, and that distinction lies entirely in the objective. A retail environment is fundamentally transactional.
It's just about making a sale.
Exactly. It's designed to sell you an in-stock, over-the-counter insole based on a really superficial reading of your foot, usually just to provide, immediate but temporary comfort.
Like a quick fix.
Yeah. But true clinical care, on the other hand, is diagnostic. It's all about identifying those silent red flags early by understanding why the structural foundation of your foot is failing in the first place, so you can actually keep moving safely over the long term.
Okay, so let's unpack this. Because before we can even talk about recognizing a specific diabetic red flag, we really have to understand how a professional actually looks for one. We're moving from the general concept of just, buying a shoe insert into the actual methodology of a clinical assessment.
Which is step 1 for any real professional.
Right. And to me, buying an off-the-shelf retail insole to try and fix a fundamental gait issue, it's like putting a bucket under a leaky roof instead of just finding the hole, Or like trying to fix a grinding, misaligned gear inside a Swiss watch by just spraying it with WD-40.
That's a great way to put it.
It might stop squeaking for a few hours, but that gear is still tearing itself to pieces every time it ticks. So tell me, why is identifying changes in a person's gait and pain patterns the absolute non-negotiable prerequisite for a pedorthist?
Well, you have to look at the body as a kinetic chain. Your foot doesn't just operate in a vacuum.
Yeah.
The specific angle at which your heel strikes the ground that dictates the rotational forces on your ankle.
Okay.
And then that rotation transfers up your tibia to dictate the alignment of your knee, which in turn influences your hip placement and even the curvature of your lower spine.
Wow, so it goes all the way up.
All the way up. And every single time you take a step, your foot absorbs ground reaction forces equal to like 2 or 3 times your total body weight.
That is a lot of force.
It is. So if your mechanics are off by just a few degrees, that entire kinetic chain has to absorb massive amounts of misdirected energy.
So a retail store that just, has you stand on a static pressure mat is missing the entire picture.
Completely. They're capturing a snapshot of a stationary object.
Yeah.
But walking is this dynamic, highly complex sequence of basically falling forward and catching yourself.
Falling and catching yourself. I like that.
Yeah. So when a clinical pedorthist evaluates your dynamic gait, they are looking for these microscopic compensations. Like, perhaps you're rolling the outer edge of your foot slightly to avoid a hot spot on your big toe.
Right.
Or maybe your arch is collapsing just a fraction of a second too early during the mid-stance of your stride. These hidden mechanical failures are the earliest whispers that your alignment is compromised.
And you just can't see that if you're just standing still.
No, you only see them when the body's in motion, managing those ground reaction forces. So without assessing the dynamic gait, any intervention is really just a shot in the dark.
Okay, so once you see those microscopic compensations in the dynamic gait, what physical markers confirm that the foundation is actually breaking down? This kind of takes us to the visual indicators. Looking through these clinical notes, there is a major focus on structural shifts, specifically bunions and hammer toes.
Right. Those visual indicators are the physical manifestation of those misdirected ground reaction forces we just talked about. When the mechanics are wrong for years, the physical architecture of the foot eventually just surrenders to that uneven pressure.
So what does this all mean? Because I have to play devil's advocate here.
Go for it.
Aren't bunions and hammer toes just, well, a normal part of getting older? Or maybe like the penalty for wearing really narrow, pointed shoes in your 20s?
A lot of people think that, yeah.
Right, like why should you, as the listener, view a bunion as a serious clinical red flag rather than just an ugly joint that makes sandal season a little embarrassing?
That assumption is incredibly common. But a bunion is not just a calcium bump on the side of your foot.
Right.
It is a severe subluxation. Basically, a partial dislocation of the first metatarsophalangeal joint.
Wait, a dislocation?
Yeah. The long bone of your foot is physically migrating outward, away from the center of your foot, while the big toe is actually being pushed inward.
So the actual bones are separating.
Yes. And because of that kinetic chain, this triggers a total cascade of mechanical failures. The tendons that run along the bottom of your foot, which are, supposed to pull straight across that joint to help you push off the ground, they're now sitting at this really harsh angle.
Oh, wow.
Yeah, so they start acting like a bowstring.
Yeah.
Every single time you take a step, those misaligned tendons actively pull the toe further and further out of alignment. It's this progressive structural warping.
That sounds incredibly painful. And if you just leave it alone, what does that warping do to the rest of the foot?
Well, your body weight can no longer distribute properly. For an average person, the shifted mechanics lead to chronic knee or hip pain. But for a listener managing diabetes, this structural shift is an absolute crisis.
Because of the neuropathy?
Partially, but also mechanically. The deviated bone creates a massive high-pressure protrusion inside the shoe. And that protrusion generates intense friction. Friction shears the skin, which creates blisters.
And blisters become ulcers.
Exactly. Blisters break down into open ulcers. In a diabetic foot with compromised circulation, an open ulcer can just rapidly lead to severe infection and quite frequently amputation.
Gosh, that escalates so fast.
It does, which is why a pedorthist attacks a bunion immediately. They use specific interventions like custom orthotics and smart footwear designed with rigid rocker bottom soles.
Okay, explain that rocker bottom sole to me, because how does a shoe actually stop a bone from migrating?
So a rocker bottom sole is physically curved on the bottom. Think of it almost like the leg of a rocking chair.
Okay, I can picture that.
During a normal stride, your toes have to bend upward at a sharp angle to push off the ground, right?
Right.
Well, if you have a severe bunion, bending that damaged joint causes agonizing pain. And it actually forces the bone further out of place. A rocker bottom shoe alters the physics of your stride.
How so?
It allows your foot to literally roll forward through the step without requiring that damaged toe joint to flex or bear that extreme propulsive load.
Oh, that's clever.
Yeah, you're offloading the mechanical stress, which halts the progression of the structural warping and keeps the patient active.
Okay, so a bunion is the flashing red flag that we can see. But that brings us right back to our opening analogy about the unplugged security system.
Right, the silent burglar.
Exactly. What happens when the warning system goes totally offline? We are moving into the most critical segment of this diabetic foot care series, which is conditions where the pain is entirely masked. And here's where it gets really interesting, because the clinical notes emphasize advanced Charcot foot stabilization and managing diabetic neuropathy.
Yes. Neuropathy is the mechanism behind that unplugged alarm. And to understand why this happens, we really have to look at the biology of diabetes.
Okay, break it down for us.
When a person has chronically elevated blood sugar levels, that excess glucose acts almost like microscopic shards of glass traveling through the bloodstream. Over time, this hyperglycemia damages the delicate inner lining of the capillaries. Those are the tiny blood vessels that supply oxygen and nutrients to the nerves in your extremities, like your toes.
So the nerves are literally being starved of oxygen.
Precisely. They suffocate and die. The peripheral nervous system degrades, starting at the toes and slowly moving upward. So the patient just loses the ability to feel heat, cold, or pain in their feet.
Wow. So if we go back to our analogies, developing a Charcot foot while having neuropathy is almost like playing a game of Jenga.
Oh, that's a good comparison.
Right, like you are pulling out the load-bearing wooden blocks from the inside of the tower. The outside of the tower still looks perfectly fine, but the internal weight distribution is completely compromised. And because you can't feel the pain, you just keep stacking blocks on top until the whole thing spontaneously crashes to the table.
That is exactly what happens on a skeletal level. Because the neuropathy masks the pain. A person might suffer a microfracture in a metatarsal bone simply by, stepping off a curb too hard.
Just a normal step.
Yeah. A healthy person would instantly limp and stay off that foot. But the neuropathic patient feels absolutely nothing. They just keep walking on a fractured bone. And that repetitive trauma causes the bone to break down further.
And I've read that the blood flow changes in Charcot foot actually make the bones softer too. Is that right?
It is. The nerve damage often triggers an autonomic nervous system response that increases blood flow to the foot, which ironically stimulates these cells called osteoclasts.
Osteoclasts.
Yeah, and these cells actually wash out the calcium from the bones, turning them soft, almost like chalk.
Oh my gosh, like chalk.
Just like chalk. So between the soft bones and the constant walking, the joints fully dislocate. The arch of the foot eventually collapses downward, reversing its shape entirely into what clinicians call a rocker bottom foot.
So the structural integrity is just gone.
Completely gone.
Well, if the patient can't feel a massive internal fracture, how does a pedorthist actually catch this in a clinical assessment before the arch collapses?
You have to look for the secondary alarm bells. Since pain is offline, a clinician looks for localized heat, visible swelling, and joint instability. Because of the bone trauma and increased blood flow, a Charcot foot will often feel significantly warmer to the touch than the other foot.
Ah, so temperature is the giveaway.
Yes, catching that temperature difference early is absolutely paramount.
Okay, so once they catch it, the source material notes they use tools like a Diabetic Neuropathy Gauntlet. But I mean, how does a gauntlet physically stop a soft, crumbling arch from collapsing under the weight of an entire human body?
By bypassing the foot entirely.
Wait, what?
Yeah, a diabetic neuropathy gauntlet is a highly specialized, custom-molded ankle-foot orthosis. It's built using these rigid thermoplastic shells that encapsulate the foot, lock the ankle at a precise angle, and then extend all the way up the back of the calf.
Okay.
So when the patient takes a step, the rigid structure of the gauntlet takes the ground reaction force and redistributes it. Instead of the force traveling up through the fragile bottom of the foot, the weight is transferred directly into that heavy thermoplastic shell and dispersed across the much larger, stronger surface area of the calf and shin muscles.
Oh, wow. It's literally an external skeleton. Like, it takes the load-bearing weight off the crumbling Jenga tower and routes it into the surrounding scaffolding.
Exactly. It provides total contact offloading. It holds the bones in a static, protected alignment so they can eventually fuse and heal without collapsing. It really is the ultimate protective solution to safeguard long-term mobility when the body's internal support system has just completely failed.
That is brilliant biomechanics. Really incredible. So we've walked through the severe red flags, the visible alignment failure of bunions, and the terrifying silent collapse of Charcot foot. Once the clinical assessment flags these dangers, how does the pedorthist actually execute the solution? Because the practice notes outline this personalized treatment plan featuring custom orthotics and precision fitting.
Right, so the execution hinges on manipulating that kinetic chain we discussed earlier. Once the pedorthist knows exactly where the mechanical failure is, they create a custom orthotic device specifically engineered for that individual's gait.
Let's talk about the physical construction of these custom orthotics, because we aren't talking about those flimsy foam inserts you buy at a pharmacy, right?
Oh, not at all. These are real medical devices built from highly specialized materials. The pedorthist might use a rigid carbon fiber base plate to provide absolute control over the heel and arch, which prevents that early collapse during the mid-stance of the stride.
Carbon fiber, so it's super strong.
Very strong, but lightweight. And then on top of that carbon fiber, they layer varying densities of materials like EVA foam or plastozote.
What's plastozote?
It's a closed-cell foam, and it's particularly crucial for diabetic patients because it conforms to the shape of the foot under body heat. So it eliminates those high-pressure points and prevents the friction ulcers we talked about earlier.
Okay, I follow the materials and the engineering. It makes total sense. But I have to push back on one specific part of Michael L. Ashley's methodology here.
Sure.
If these orthotics are entirely custom built from a professional, highly detailed clinical assessment, why is there such a massive emphasis on a precision fit and follow-up phase? I mean, shouldn't a custom medical device built from advanced materials be absolutely perfect the second you slide it into the shoe?
Well, that assumes the human body is just a static block of wood, but biological tissue is incredibly dynamic.
Okay, fair point.
Let's say you introduce a highly supportive, biomechanically corrective carbon fiber orthotic to a person who has been walking with severely pronated, misaligned arches for 10 years. You are instantly altering the physics of their gait.
You're forcing them to walk correctly for the first time in a decade.
Right. And their body is going to aggressively react to that new posture.
Oh,
Over those 10 years, their neuromuscular pathways literally rewired themselves to accommodate the bad alignment.
oh, I see.
Yeah, certain ligaments have become permanently stretched, while other muscles have completely atrophied from lack of use. So when the orthotic forces the foot into a mechanically advantageous neutral position, those dormant muscles suddenly have to wake up and fire again.
So it's going to ache, like going to the gym after years off.
Exactly. It will ache, tendons will stretch,
Yeah.
and quite literally the physical volume of the foot might change.
Wait, the volume of the foot, like the size changing?
Yeah. As the arch is properly supported, the foot might become slightly shorter. As inflammation decreases, the width of the foot might narrow. So an orthotic might perfectly match a 3D scan or plaster cast of your foot taken on Tuesday. But how does that device behave when you put your full body weight on it dynamically inside a specific leather shoe while walking at 3 miles an hour 3 weeks later?
It shifts.
It absolutely shifts. That is why the clinical notes make a very specific point, that fine-tuning is mandatory so that footwear and mechanics work together.
So they have to adjust it on the fly.
Right. The pedorthist has to observe the patient walking with a new device. They might heat mold adjustments, grind down the foam, or even alter the pitch of the shoe itself. It reinforces the core philosophy of clinical pedorthics, which is that diagnostic knowledge is only valuable when it is carefully applied and meticulously monitored over time as the body adapts. Handing someone a custom insert and saying good luck just isn't healthcare. Follow-up is the definitive proof of clinical care.
Man. Which brings us full circle to the true mission of this deep dive. Recognizing red flags isn't just about looking down at your toes and checking for a blister.
Not at all.
It is about actively evaluating your dynamic gait, taking your pain patterns seriously, and correcting your alignment to catch these mechanical issues before a total structural collapse even happens.
Exactly.
And honestly, whether you are actively managing a condition like diabetes or you're simply someone trying to get out of bed and walk down the stairs without wincing, addressing the root biomechanical cause is the only real way to hurt less and perform more.
You simply cannot fix a dynamic biological problem with a static, generic retail solution.
You really can't. Now, as we wrap up today's analysis, there is one final, really compelling thread hidden in these practice materials that applies to a completely different demographic.
Yes. Throughout this discussion, we really have focused intensely on the severe medical extremes, right? Diabetic neuropathy, total arch collapse, subluxated joints. But Michael L. Ashley's clinical materials also heavily feature something called the Gold Standard Work Fit Package.
Right. This is a program built specifically for occupational workers.
Exactly. It pairs hands-free, slip-resistant footwear with custom biomechanical orthotics designed specifically for people like nurses pulling 12-hour shifts on hospital floors, or warehouse staff walking on concrete all day, and culinary professionals.
People who are just constantly on their feet.
Right. And looking at that program really drives home a broader point about how we view pain. We've talked endlessly about diabetes turning off the body's alarm system. But we also have a cultural habit of turning off our own alarms voluntarily.
Oh, totally. We normalize the pain. We assume that if you work a grueling 8-hour shift on your feet, you are just supposed to be in agony when you get home.
Yeah, we just brush it off as tiredness. But think about your own daily work environment. Is that deep, aching, throbbing foot pain that you consider just a normal part of your job actually an early red flag of kinetic chain failure?
Is it that misaligned gear and the watch starting to grind?
Exactly. It is very likely a warning sign that a thorough clinical assessment could have caught and corrected years ago before it ever progressed into permanent structural shift.
Wow. That's a huge takeaway. Don't let the alarm unplug itself, and definitely don't unplug yourself just because you think pain is part of the job.
Couldn't agree more.
Well, thank you all for joining us on this deep dive into the mechanics of the foot. Keep paying close attention to those red flags, and we'll catch you next time for the final part of our series.